I want to welcome Bob Kaplan back to California. Bob Kaplan, many of you know, has had a long, distinguished career both in California and federally. He's just returned from federal service in the director's office at the National Institutes of Health and as the chief science officer of the Agency for Healthcare Research and Quality. He's now Arnie Milstein's chief science officer at the Stanford Clinical Excellence Research Center. And he is a longtime RightCare family member. He first started working with us when he was in charge of health services research at UCLA, and he gave us the greatest gift. Working with Alan Fremont here from RAND, they put in an NIH request for funding to implement the promising interventions on the RightCare triangle in one community. And the community that was selected by Bob, in part because he knew everyone in San Diego, because he had worked at UC San Diego, and in part because we had some really concerning performance scores in San Diego. That NIH grant was devoted to raising the scores and the performance outcomes in one community, and that was what launched the San Diego University Best Practices. And you will hear later today that acute myocardial infarction hospitalizations in San Diego have fallen 20% since the inception of that program, which is really phenomenal. And he is going to help us figure out how to get those sorts of results statewide. So with that, we're going to hear from Bob Kaplan. Bob, please join us.
Patty, thank you so much. It's such a pleasure to be back with the RightCare group. And as Patty mentioned, had a big formative influence on my time in Washington, now back in California. So it's just terrific to be back. Before I go much further, I should go through my disclosures. Patty mentioned that I had spent some time at the NIH as one of the associate directors of AR, and I was a board member of Corey. And I just want to emphasize that although the program says former chief science officer at AHRQ, nothing I say today has anything to do with that. I'm in what's called my cooling off period. So for a period actually of 2 years, I need to be separated from what those agencies do. So whatever I say today is just me. So let me begin by saying that I have three objectives today, just 3 points that I'd like to make. First one is that we're doing well, actually not exceptionally well in healthcare. The second is not to be fooled by surrogate markers, which has been a lot of the emphasis in some of these efforts. And third, that the clinical model for managing coronary heart disease risk factors has some limitations. Now, I want to begin by saying, well, what is it that we are telling people about how we're doing in medicine and healthcare? I want to raise this because that there seems to be a discrepancy between what we tell the public and what we tell each other as scientists and physicians. So we tell the public that we have the best medical care system in the world. And we tell people that U.S. biomedical research is second to none. My time in NIH was really interesting for me because I would come in each day. It's very different than being a university professor. So I didn't have control over my own calendar. It was typical in the office of the director that my calendar would be filled and people would come to see me almost all day, every day. And what did they tell me? Well, the first thing they told me was they needed more money for biomedical research and they needed more money for clinical care. And so that the solution was more money and then more money. And here's how NIH made the arguments to Congress. They argued that because of investments in NIH, we're doing really well. So for example, there's been a substantial reduction in deaths from coronary heart disease, that HIV therapies have enabled people infected in their 20s now to live into their 70s. There are increased survival rates from cancer. And all this leads to changes in life expectancy that has a net worth of about $3.2 trillion annually. We're doing well. or with regard to coronary heart disease or deaths from MI and stroke, there's been a precipitous decline that goes back to the late 1960s. So as you can see in this graph, heart disease has been declining, stroke has been declining quickly. We're doing very well. And you might ask, well, how did we do this? Well, we did it by identifying the mechanisms of disease in preclinical research, and then in the clinic, we improved diagnosis. And then using evidence-based interventions, we fixed problems. So we did it with a find it, fix it model. But what I'd like to raise with you today is, how well are we really doing this? Because people made the argument, and in fact, this was the argument that I heard over and over again when I was at the NIH, that we need to do exactly what we're already doing. We just need more money to do exactly the same thing over and over again. And I want to raise this question, how well are we doing? Well, first, one of the mismatches is that health outcomes in the United States are the very best in the world. And I think this group is familiar with this. Actually, a lot of the groups that I dealt with in Washington were not quite as aware of this. When I was at the NIH, our office sponsored a study done by the Institute of Medicine, now called the National Academy of Medicine, where we looked at health outcomes in the US versus other rich countries. And so these are the countries that were in the comparison. They were countries that were the top economies in the world that had comparable data. So most of these countries were in North America and Western Europe, but it also included Australia and Japan and Canada. So, oops, what have I done here? One of the things that came out of that study was the realization that since about 1980, that health outcomes in the United States have been declining relative to other rich countries. So back in about 1980, the US was about in the middle of the distribution of these wealthy countries. Since 1980, we found our way to the bottom of this distribution for both men and for women. And the committee that did this report was chaired by Steve Wolf at Virginia Commonwealth University. This committee also looked at a variety of other indicators, one of which is what demographers refer to as the P50, that is the probability of surviving once you reach the age 50. And the other one was, what's the probability of getting your 50th birthday? You might imagine it this way, it's your 50th birthday, they're going to bring out a big cake for you, and the question is, are you alive to blow the candles out? And it turns out, on this indicator, the United States is doing remarkably poorly. So that for both men and women, we've lost ground, and we've lost ground rather rapidly over the course of the last several generations. And so the U.S. loses losses of life before age 50 are about double what they are in Sweden. And in fact, for women, this has become a more severe problem. So you can see on the left side, for men, we were toward the bottom, but we're all the way down at the bottom now. But for women, we've completely gone off the scale over the last decade and a half. So that's the question of, well, are we really doing that well? The second question I want to raise is our concentration on surrogate endpoints. I think many of you are familiar with this, but I just want to bring it up for discussion as we talk about how we improve health outcomes for the future and what we concentrate on as health groups. So, one of the issues that we have raised over and over again is, what are we trying to achieve? Are we trying to achieve lower blood pressure and lower cholesterol, or are we trying to achieve longer life and improve quality of life? And the argument that we've made is that blood pressure and cholesterol are important and other risk factors because they're associated with increased life expectancy. And in fact, if they weren't associated with improved life expectancy or improved quality of life, the argument would be that they're really not that important. So those indicators are important because they're correlated with outcomes. But in fact, we need to concentrate on the outcomes, not on the surrogates. And so we raise this question, for example, is being dead from cancer worse than being dead from something else? Well, we know from a variety of clinical trials that if you focus too specifically on a particular cause of death, you miss the big picture. So for example, in the physician's health study, the aspirin component, physician subjects were randomly assigned to aspirin, 325 milligrams once every other day, or to placebo. And then the study was stopped early because there was a lower rate of myocardial infarction in the aspirin group than the placebo group. But if you just look at the causes of cardiovascular death, in fact, there was no advantage of aspirin whatsoever. That in fact, total number of just cardiovascular deaths and total deaths in this study, by the way, these are all premature deaths, they were deaths within the study period, are exactly the same. There's a whole lot of work that's been emerging from the NIH in this area that looks not only at surrogate markers, but looks at animal outcomes. And I mention this because that only about half of the NIH budget is spent on human studies. So my colleague, Robin Barr, who is the Director of Extramural Research at the National Institute on Aging, argued that, that we need to look carefully at what the outcomes are in the animal models that we look at. I'm reminded of this quote from Norbert Wiener, who said, "The best model of a cat is another cat, or preferably the same cat." Barr pointed out that we've cured Alzheimer's disease 300 times in mouse models, but he says, but so far failed to cure it in any humans. He was referring to 221 consecutive randomized clinical trials funded by NIH, all of which have failed to show clinical benefit for Alzheimer's disease. And to make this, sort of bring this point home with regard to surrogate markers that we use in cardiovascular research, it's been shown in lots of studies that people randomly assigned to interventions that lower glycosylated hemoglobin or blood sugar have been successful. So the DPP is the most famous study. I think everybody knows that one. But in fact, as you can see in this meta-analysis, the DPP at the top produces a similar result to lots of studies. So intervention lowers glycosylated hemoglobin levels, which is very impressive. But in fact, when we look at the outcomes in these trials, in cardiovascular mortality or all-cause mortality, in fact, there appears to be no benefit. In fact, when we look at what's happening in industry, if you just take this discovery pipeline, so we say, well, of the compounds that are patented, how many of those end up being drugs approved by the FDA? So among 10,000 compounds, only about 250 of them get into preclinical studies. Only about 5 get into clinical trials. Among those, only 1 of the 10,000 ends up being a patented product. So let's look a little bit more carefully at what happens in those studies of patented products. So this is just starting with the preclinical side. These are animal studies. These are studies done on ALS, and there's an organization which is an ALS Therapy Development Institute, which takes published trials. These are all animal trials. The blue bars are the published studies. And then the black bars are the replications, exact replications that are performed by this independent group. As you can see, of all these studies in animal models showing that these molecules work, it turns out that none of them are replicated. This is sort of a familiar story in the Care Initiative where we just talked, I think we'll just skip this because we all know what causes heart attacks. But the argument is that if you take, these are people without acute coronary syndrome, so people who have stenosis of their coronary arteries, and if you put a stent in, it should fix the problem. So we can fix that. But in fact, the NIH has been doing these large randomized clinical trials where people are assigned to a stenting or to usual care medical management. And in fact, when we look at the outcomes, again, the intermediate outcomes look good, but if we look at the all-cause mortality outcomes, or in this case, all the other outcomes, there's no benefit whatsoever. This is the ACCORD trial. People in the ACCORD trial were randomly assigned to standard therapy or intensive therapy, and you can see that if you look at glycosylated hemoglobin, it looks very good, so this problem is fixed. But in fact, when we look at death from any cause on the right side of this slide, it's not just that people don't, that the intensive therapy intervention does it the same. In fact, it does work. There was actually a significant increase in deaths for people that were in intensive therapy. This is just another one, diabetes study. This problem is fixed, but when we look at outcomes, no benefit. This is a study for people with anemia. People with advanced renal disease or cancers, they get erythropoietin-stimulating agents. Group 1 gets the agents, so their hemoglobin goes up, and then group 2 is usual care, so this problem is fixed. But in fact, when we look at the outcomes, there's no benefit. I have a lot of these. The THRIVE trial increases HDL, decreases HDL. I guess I missed it. I should say that whenever I give a talk, I just go to the New England Journal of Medicine that week. And so this was 2 weeks ago. This is a COPD trial. I'm going to skip that one. This is last week's New England Journal of Medicine. COPD patients assigned to long-term oxygen therapy versus usual care, and these are the outcomes. And this morning I got up and looked at the New England Journal for this week, and this was a study of 2 anticoagulants, sort of head-to-head comparison, and the primary outcome was a composite of cardiovascular death, myocardial infarction, or ischemic disease, and same story. In fact, you might ask, are we cherry picking? Am I doing this just picking the ones that didn't come out? So when I was at NIH, I had the opportunity, because I had access to big databases at NIH that other people didn't have access to, and we had the opportunity to look at all the randomized clinical trials that were supported by NHLBI over the last 50 years. Something very interesting emerged from that, and that is that before 2000, there were a lot of positive trials. Since 2000, there have been very few of them. And we think the reason for that is that in 1997, the FDA Reauthorization Act required people to list their trials in a service called clinicaltrials.gov. So now you have to specify your primary outcome variable when you start the trial. And so what we found was that prior to the year 2000, on the left side, you can see that there were quite a few positive trials. The positive ones have little pluses in them. After 2000, there are very few. In fact, when you look at the meta-analysis, that on the left side, the dark bars, the dark squares are trials where there was a positive result, and the gray ones are null trials. So on the right side, you can see that after the year 2000, there actually have only been 2 positive trials. There's a new one, which is Sprint. And if we look at all-cause mortality, in studies that claim they were powered to evaluate all-cause mortality, there actually has not been a positive trial in about 16 years. Although I shouldn't say that, because the Sprint trial, which came out last year, was after this was published, was positive. It actually turns out to be fairly rare. So the last problem I want to talk about today is quality and compliance, and how we're dealing with cardiovascular risk factors. And I'm doing this because that when I was at ARC, one of the things I did as part of my job was I helped oversee the U.S. Preventive Services Task Force, and that I knew that this was coming out. It turns out that the task force has just published, will publish tomorrow in JAMA, the recommendations on management of cardiovascular risk factors. So it's actually was released to the press last night, so a lot of this is in the newspapers this morning. So here's the issue. And these are, by the way, the editorials which appear in this week's JAMA, and all of them say statins for primary care, the debate is intense, interpretation and use of another statin guideline, which now the task force is recommending something different than the other guidelines, and then uncertainty and the need for more evidence. And I want to just sort of start by saying that when we think about risk factors for heart disease, in fact, we often ignore the risk factors which are the most important ones in the Framingham equations. So for example, age is a huge factor, which I'll get to in just a minute, as is race and as is sex. So just take this example. This is an example of a 70-year-old man. He has a total cholesterol of 160, a blood pressure of 125/80. He's a non-smoker, non-diabetic. And the equation says that he's got a 10-year risk of 15.9%. And so that when you run these numbers through the calculator, it will come back and say aggressive statin therapy. And if he gets aggressive statin therapy, it reduces his risk from 15.9% all the way down to 14.5%. Now let's take a 60-year-old man. And because I don't want to spend that much time on this, I just want to say that everything's exactly the same. And so the 60-year-old man has all the exact same numbers. But his risk is 7%. And so the question is, well, are we treating age with statin? Because his lipid numbers are all like exactly the same. And this is the big debate that emerges in this discussion that you see in John this week. I want to give you the second example. So this is a 60-year-old white man, actually the same numbers, so you don't even have to read them. But the 60-year-old white man has a 10-year risk of 7%. By the way, I forgot to say that if your 10-year risk is above 7.5%, then you'll get this note that says aggressive statin therapy. And so for this 60-year-old white man with these numbers, the advice is no intervention required. But if it's a black man with exactly the same numbers, his risk is 7.5%, and it comes back with this advice, aggressive statin therapy. So the question is, are we treating his blackness or risk? And the question is the statin component dealing with what puts that black man at increased risk? Actuarially, he is at higher risk. The second question, which this task force deals with, is in fact, by the way, you can't really get, when you get to be my age, you can't get below 7.5%. So everybody that's over 65 is going to be told to be on aggressive statin therapy. But it turns out, as the task force points out, that's actually the area where there's the least evidence. So clinical trials have many fewer participants in the older age groups. And when you get above 75, there's essentially no evidence. And so it's very hard to sort of, this is in precision medicine. Everybody gets treated the same way. And in fact, there are a bunch of meta-analyses that have appeared in the literature saying that in fact, in at least observational studies, there's an inverse association between low-density lipoprotein cholesterol and mortality. So those actually that have higher levels actually have lower levels of mortality.
After a certain age, right?
After a certain age, yeah. So last, I have just a couple minutes, so let me get to the last issue, which is, well, you know, what should we be doing? Are we on the right, if we're not on exactly the right track, and I'm a big fan of all the things we are doing, but should we be doing some other things? Should we be thinking about some other issues in research and in practice? I just want to point out, as many of you know, that when we look at the proportion of variance in outcomes associated with different factors, healthcare accounts for a relatively small percentage of the variability. And these other factors, behavior patterns, social circumstances, genetic disposition, and so forth, account for a much larger percent. By the way, this has been analyzed in this book I'm working on. I looked at all the different ways this has been analyzed, so about 6 different methods, 4 predominant methods, and all of them come to very similar conclusions. Just to give you a sense of some of the things that we're not paying attention to, if you look at, well, what are the best predictors of stroke and MI? It turns out that many of them arise outside the healthcare system. So, for example, I worked with a group at the University of Alabama at Birmingham, just looked at what are the best predictors of stroke and MI in a big database involving about 30,000 people followed prospectively. Well, it turns out that the very best predictor in this database was number of years of education completed. So the base case is less than a high school education. They have almost 3 times the rate of death, adjusted for other factors. And then the best group is a college graduate or more. If you adjust this for demographic variables, it doesn't go away. If you adjust for income, or if you adjust for all biologic risk factors that were measured in this data set, it still doesn't go away. And then you add behavioral factors on top of that, it still is strong and linear. And then if you ask, well, how strong is this effect in relation to things that we know about? So the U.S. Preventive Services Task Force debates forever about should women get pap smears every year or every 3rd year? Well, it turns out that whether you get a pap smear every year or every 3rd year will affect your life expectancy by about a day to 3 days. Mammography screening, which has been a big controversy for the task force, at the end of the day, looking at randomized clinical trials, maybe a month of life expectancy. Normal LDL cholesterol versus LDL cholesterol is above 160 based on the Whitehall study. It's about 6 months, blood pressure about 8 months, smoking is about 6 years. But the difference between someone with less than a high school education and a graduate degree is about 12 years. So it's an enormous factor. So what are we going to do about this? Well, I've been trying to argue in this manuscript that I'm putting together that we need to start looking at this differently. First, demographic and social factors really do matter. And in fact, we don't know very much about them in patient populations. So there's a report from the National Academy of Medicine that was released about 2 years ago, chaired by Nancy Abdul from UCSF and Bill Steed from Vanderbilt, that said we just need to capture this information in the electronic health record. And they provide very specific information and guidance on how this should be done. Second issue is, are we doing this right? So for example, is it the right model to wait for people to develop risk factors, or should we think about preventing risk factors from developing in the first place? And this analysis by Don Lloyd-Jones from Northwestern, I think is very, very interesting one. So they just look at risk factors prior to age 50 and their relationship to outcomes. So it turns out that if you have two major risk factors before the age 50, on the left are men and the right are women, this top line, you have surprisingly high probability of an incident of one of these events. But if you look at the bottom line, these are people that make it, men and women, who make it age 50 without risk factors. They're in remarkably good shape. So it raises the question, should we in these medical groups be devoting more of our attention to preventing risk factors from developing in the first place? And finally, my colleague and friend Neil Halfon at UCLA argues, well, maybe it's time to rethink the way the system works. He argues that we built a healthcare system around best science at the time, the germ theory of disease. And so the germ theory of disease, we dealt with disease when people got sick. We treated them in an industrial model because hospitals still kind of look like factories. And the goal was to reduce death. But what happened was that science moved on. That in fact, that the Framingham Heart Study came along, other epidemiologic studies identified multiple risk factors. And so it wasn't just germs, it was other things. And so instead of treating people when they got sick in acute care situations, we developed ambulatory care and another model that we've been talking about in the right care. And the idea was to promote disability-free death. And Neil argues that our current healthcare system is somewhere between the first era and the second era. But the problem is that science has moved on again. So now we have a new science that involves complex systems, life course, pathways, social determinants of health, and so forth. And we're still trying to deal with this with a system that's out of date. And so his argument is that we need to sort of redo this healthcare system. And it might be worth just thinking about what it looks like. And this slide comes from the Chief Strategy Officer at Cerner, Joanne Burns. And it's a little bit hard to follow, but her argument is, I have a pointer. There we go. So the argument is that you have discoveries and populations feeding into this, and you have healthcare reform and aging populations, and then you have the institutions to deal with them. And over here you have the care side with the big tall hospital. And the argument is, well, we have all these other factors that influence health, like schools and gyms and churches and so forth. The argument is, well, maybe that in the future, the hospital should be a shorter building, and maybe the school should be a larger building. So, there we go. So in summary, I'm trying to make these points. I think that we're doing well in healthcare, maybe not that well. And it might be time for us to rethink not only how we deliver healthcare, but how we make investments in new knowledge. Secondly, don't be fooled by its surrogate markers. I think it's important to emphasize surrogate markers, but we need more study to learn a little bit more about how these surrogate markers relate to health outcomes. And finally, the clinical model of managing cardiovascular risk factors has limitations, and we need to think about new ways of addressing it, primarily involving social determinants and other factors. So I know that the first speaker quoted Einstein, so let me finish the same way. Sanity is doing the same thing over and over again, expecting different results. So anyway, Patty, thanks for having me back. It's been fun to be here, and look forward to